Hello, I'm Jo Coburn. Welcome to Back to Health, Making Up for Lost Time, brought to you by Project Syndicate. Global economic devastation, nearly 4 million dead, and no clear end in sight. The COVID-19 pandemic has been by far the global economic devastation, nearly 4 million dead, and no clear end in sight. The COVID-19 pandemic has been by far the greatest crisis of most of our lifetimes. But could there be a way to prevent another pandemic from happening? Is it hubristic to even think we can? And now, at a moment when the world's resources are uniquely focused on one health crisis, can we realistically lay the groundwork to tackle what some might call another of similar proportion, bringing health coverage to the 50% of humanity who lack it? Those questions will drive our 2 sessions today, and we'll have some of the most qualified people alive on hand to answer them. Dr. Tedros Adhanom Ghebreyesus is the Director General of the World Health Organization. Gro Harlem Brundtland used to do the same job, and before that was Norway's first female Prime Minister and is now a member of the Elders. We have another former Prime Minister, Australia's Julia Gillard, who is now Chair of the Global Partnership for Education. Angus Deaton won the Nobel Prize for Economics and is one of the world's leading experts on development and inequality. David Miliband was once the British Foreign Secretary before becoming President and CEO of the International Rescue Committee. Tom Frieden is the former director of the CDC and is President and CEO of Resolve to Save Lives. SETH BERKLEY is the CEO of Gavi, the Vaccine Alliance, and Werner Hoyer is the President of the European Investment Bank. Now, today isn't all about the bigwigs. It's just as much about you, the audience at home, around the world. So do please get involved using the hashtag #BackToHealth. Now, what better way to kick things off than hearing from Dr. Tedros Adhanom Ghebreyesus, Director General of the World Health Organization.
Dear colleagues and friends, the COVID-19 pandemic is the worst global crisis since the 1940s and the worst health emergency since the 1918 flu pandemic a century ago. Despite years of warnings by WHO and others, most countries were not prepared.
If anything kills over 10 million people in the next few decades, it's most likely to be a highly infectious virus rather than a war. Not missiles, but microbes.
There are many lessons to learn. First, global preparedness starts with national preparedness. Every country must invest in its public health capacities. Second, the fundamental weakness at the root of the pandemic is the lack of global solidarity and sharing of data and information, sharing of personal protective equipment, and sharing of oxygen and vaccines. That's why there is now an emerging global consensus for the idea of an international agreement, framework, convention, or treaty. Call it what you will, to improve global cooperation and to strengthen the implementation of the international health regulations. WHO's member states have agreed to consider this idea at a special session of the World Health Assembly in November. COVID-19 has taken so much from us, but it's also giving us something, an opportunity to build a healthier, safer, and fairer future for all of us. I thank you.
That was Dr. Tedros Adhanom Ghebreyesus. Now, I'm delighted to introduce our first panel of the day, here to discuss how we can prevent the next pandemic. Tom Frieden was the director of the CDC under Barack Obama, and before that, commissioner of the New York City Health Department. He's now president and CEO of the global non-profit Resolve to Save Lives. David Miliband, Former British Foreign Secretary is the President and CEO of the International Rescue Committee and served on the World Health Organization's independent panel for pandemic preparedness and response. Agnes Binagwaho was Health Minister in Rwanda and now works as Vice Chancellor of the University of Global Health Equity. And Dame Sally Davies is the Master of Trinity College, Cambridge, and the UK Special Envoy on Antimicrobial Resistance, having worked as the Chief Medical Officer for England until September 2019. Welcome to you all. In about half an hour, we'll be taking questions from journalists from around the world, so do stay tuned for that. But first, let's remind ourselves of the issue. Now, before we get started, just one more reminder that if you would like to join the conversation or help share the word today, we'd be delighted if you get involved using the hashtag #BackToHealth. Now, to our all-important panellists in this session. I'd like to work through the stages of a pandemic, if you bear with me, looking at what we need to do differently next time and ultimately ask if we can really prevent another COVID, another Spanish flu, another Black Death. So I'd like us all to imagine that there is a new pathogen. I know that is difficult at the moment, with the potential to be another COVID or worse. So to begin with, let's start with the moment that a pathogen is identified for the first time. David, you served on the independent panel for pandemic preparedness and response, which was set up by the World Health Organization to look at how we can be better prepared. One of the things the panel said was that the formal framework for raising the alarm internationally for this new disease is currently not just too slow, but could even stop the immediate response we'll need. Why?
Thanks very much, Joe. The first step in the circumstance that you described, an organization and for proper genomic sequencing to take place. Tom Frieden, one of the panelists, will talk, I hope, in a moment about some of the targets that he's set for how long that should take. But I think the first big reform that we need is the way in which the global health governance system treats the possibility of a pandemic. Something called the Declaration of a Public Health Emergency of International Concern did not happen until the 30th of January 2020, a year and a half ago. The first meeting of the committee to assess that didn't happen until the 22nd of January, despite the notifications to the WHO, formally and informally, on the 31st of December and on the 4th of January. Pandemic was declared, and really it wasn't until mid-March that the world at a political level responded properly. And so I think there are two key lessons for the question. One is to make sure that the formal governance system works at digital speed rather than analog speed, if necessary, with proper investigatory powers for the World Health Organization. Because one of the things that strikes me as a former foreign minister is that while there are powers for the International Atomic Energy Authority to investigate nuclear questions inside countries, there's no similar power for the WHO. And the second critical element is that we need to understand as a world that pandemics are not just a health issue. They're not just a matter of health organization and for health ministers. Pandemics are an economic issue, a social issue, a security issue, a political issue, and they need heads of government engaged. And that panel on pandemic response emphasized that we need at the top of national tree a global health threats council at head of government level, so that when the alarm is sounded by the scientists and by the WHO, it's global opinion that's properly rallied at a political level.
Right, David, but you'll understand, you mentioned the political response and it being too slow, but you know what it's like in politics. Can you expect leaders around the world to really shut down their countries before they know what they're dealing with and before there really is compelling evidence? Because there is a huge cost. You mentioned the economic cost to overreaction.
Well, the cost of reaction is so much greater. We've got 5 million deaths and $30 trillion of warning in this COVID pandemic. 11 previous reports that have come out over the last 20 years have called for reforms, and they've been studiously denied. We've now had our warning, and as you indicated in your introduction, the next time an outbreak threatens to become a pandemic, it could be more transmissible and even more fatal. And so I think that we've had our warning. And what we lacked at this stage was organized international political coordination at a global level. The UN Security Council wasn't fit for purpose in this case. And that's why we've repeated the call of the Kikwete panel that came after the Ebola outbreak in 2016 to have this global political leadership where peer pressure can be organized. Because we have to remember that some leaders, some in autocratic countries, some in democratic countries, some north and some south, some did rally effectively. And we've got to make that the norm.
Right. Well, picking up on that, Agnes, many African governments were quick to respond to early reports of the COVID outbreak in China. Rwanda started monitoring for the virus and interviewing incoming travellers, pretty early on. Do you think that the sort of richer world can learn something from the response from African governments? I don't think we can hear. I don't think, Agnes, we can't hear you. Is your mic on?
I was on mute.
Yeah,
Sorry.
that's okay. Yeah, go again.
And I just want to say that it's obvious. First of all, there is no country who have 100% the knowledge of this new disease. So the only thing we did is to follow the science. We know that this type of virus is the contamination, how it's done. We know the evidence-based intervention to stop it. We didn't did, many countries didn't did it, but they didn't did it for political reason, because they were in election, because they were arrogant, because it was China, etc. So we can put the blame to anyone, but I believe we should blame the responsible, who are the leadership. You are in UK. I remember when your prime minister was laughing about it just before being sick. So don't blame WHO, China, or the others. Blame the people who did their job to protect their people. So follow the science. We know the evidence-based intervention. We didn't invent them. We apply them. We see if we have to do a lockdown, this is what we have to do to protect the poor. And the government took its responsibility and make itself ready. All countries should have done that. And you may go for any global treaty or whatever. If you don't make your leaders accountable of what the wrong decision they take by selfishness, I think we will be there for the next pandemic. And we knew it before there was the Spanish flu. Exactly the same mistake, exactly the same weaknesses. Nothing new. The poor die more. The people living in certain conditions were more affected. Nothing new. We are just lying to ourselves.
Okay, well, it's very clear you blame the lack of political leadership, as you see it, in countries like the UK. I will get some reaction from Dame Sally Davies and Tom Frieden in just a moment. I'm not saying that you represent the governments, of course, in the UK and America, but I will get your response.
And I don't represent mine. Huh?
No, well, fair enough. But it's often said, Agnes, that Ebola helped to prepare African governments for the pandemic. Is that the whole story?
No. Science is science. The whole story is just follow the science. People did follow the science. And Ebola, all the countries knew what to do. SARS-1, and all countries knew what to do. And it was exactly the same protection that should have been applied. So saying that we got Ebola is just a pretext to not recognize the responsibility of those leaders.
Okay, right, let's go back to the timing that David Miliband was talking about. Tom, I'm going to show you this tweet from January the 4th last year, when the WHO first announced that China had reported a cluster of pneumonia cases. You can see there, with no deaths in Wuhan, Hubei province. It was only then in March that this happened.
We have therefore made the assessment that COVID-19 can be characterized as a pandemic. Pandemic is not a word to use lightly or carelessly. It's a word that, if misused, can cause unreasonable fear.
So, Tom, you've also called for a new approach to early warning and response. What does need to be different next time, dealing perhaps with another pathogen? And also pick up on this point about Agnes saying it was all down to a lack of political leadership.
Well, I think first and foremost, we do have to focus on sustained political commitment, and that means funding for public health, not just when it's in the headlines, but for years and years. It means political decisions that can be difficult, that can cost political capital, like restricting travel or closing businesses. You have to be willing, as a political leader, to put lives over the interest of certain groups, the economic interests of businesses or others. But the target that we've proposed is what we're calling 717, that every country in the world, every community in every country would be able to identify the emergence of a health threat within 7 days of its appearance, would report it, begin investigation, and begin response within 1 day, and would implement effective response within 7 days. 717. If we look at global health programs, we can see the HIV world has done much better through a 90-90-90 approach, which is essentially an approach to rapidly detecting, treating, and effectively treating people living with HIV. We think a 717 type approach for preparedness could help governments really focus on what is needed. And what's needed isn't just money, although we're talking about a minimum of $5 or $10 billion a year to low and middle income countries just to build core public health capacity of laboratory networks, disease detectives, rapid response capacity, expert communication skills, reaching into communities to identify communities that may be alienated from or lack trust in the government and mainstream society, because that's where diseases can spread widely. But what we really need to recognize is that anywhere in the world where there is a blind spot, we're all vulnerable. Imagine a building with a sprinkler system, a fire suppression system, and certain of the rooms don't have an alarm or a sprinkler system. Even rooms with a good alarm and sprinkler system are going to be at risk from a large fire. And that's the kind of situation we need to recognize. We've heard about solidarity. It's not just a slogan, it's a reality. We are all connected. And if we don't do a much better job working together as a world to find, stop, and prevent health threats, the next pandemic could be even worse.
All right, well, let's talk about that sprinkler system. Sally, a feature of your current work with the Trinity Challenge is to come up with better ways to identify potential public health risks early. Do you agree with Tom that there is a blind spot to some extent? I mean, we've talked a lot about the WHO and national governments, but what more can be done by independent monitors and researchers so that we aren't wholly reliant on governments reporting crises within their own borders, which they may not necessarily want to do? And how can we make sure they're listened to?
Thank you, Joe. So we set up the Trinity Challenge, which brings together some academic centres across the world with private sector, not governments, to look through public challenge and working across the partnerships. Are there better ways of generating the data? Can we pick up spillover risk and spillover early? Can we pick up as it grows? Can we respond better, having monitored it, and even recover better? And we launched a public challenge, and it's so exciting. 340 applications for bringing the collision between data science and public health in order to help solve these problems and produce scalable public goods that can be used in low and middle income countries. 61 countries involved, 16 finalists, and I can tell you the winners who announce on Friday, are amazing for how they're bringing digital into low and middle income countries as well as rich countries. So we will be able to have surveillance that works and yet is not heavy and not expensive because so much is digital. So very exciting. But I also wanted to bring one other thing in. We're talking about insurance by having good public health systems. And of course, new data, not yet published, shows that over 1 million people die every year from antimicrobial resistance. So while we have an acute pandemic, we have a slow pandemic going on at the moment that's already killed more than COVID. So please don't forget that one, because that is going to need attention as well.
And there's been lots of discussion, of course, on that. Tom, I said I would ask you a little bit about political leadership and the reaction. The response of governments to the news of a new pandemic. Your 8-year tenure as director of the CDC ended on the day of Trump's inauguration. How surprised were you by the US response to COVID-19 3 years later?
Well, it was certainly disappointing and in a way deeply surprising, because really, if the response had been more effective, not only would tens or hundreds of thousands of lives have been saved, but quite possibly the result of the election would have been different. So you ignore public health at your peril. I will say that what we're seeing globally now is a focus on the lab leak hypothesis. And from a public health standpoint, in a sense, how it started in China is of intellectual importance, but whatever the answer, we know that we need to plug two gaps in our global preparedness. We need to do a much better job preventing spillover from animal sources, because there are major risks of that in many continents. And we need to do a much better job reducing the risk of laboratory release, because in countries all over the world, too much research is being done on too dangerous pathogens by too many people in too many laboratories. And that puts all of us at risk.
David, on the point of political leadership, are there also deeper structural flaws in the way countries run themselves and their health systems? We heard from Tom also earlier about perhaps a lack of capacity even amongst richer countries, never mind poorer developing countries. That means we will see the same thing happen again.
Well, I don't think we're doomed to see the same thing happen again. Some quite basic changes could, I think, have prevented the worst of this outbreak. And I think there are two things that are really important. First, you mentioned in your introduction at the top of the program, half the global population not having the basics of public health infrastructure, up to 3 billion people without running water in their own homes. The equity aspect of this is absolutely critical, because in a connected world, we're only as strong as the weakest link in the chain. And so I think it's very, very important to recognize that it's both the poorest people in the richest countries, but also the poorest people around the world who are going to, in the end, suffer the most. And while the race between vaccines and variants is being won in the rich world, it's being lost, frankly, in many parts, poorer parts of the world. Secondly, I think there is a big issue about the infrastructure of global coordination and global governance. I know this is an age when it's popular to say that international organizations are too strong and too overbearing. The truth is they're too weak, not too strong. The WHO needs more power, not less. It needs more power over investigations. It needs more independent funding. It needs more ability to hold governments to account for what they do. But we also need the wider political coordination that I mentioned. And so I think that the simple answer to your question is that there is, yes, a desperate need for change. And no, it's not right that we're doomed to have this happen again in a more virulent form in the next few years.
All right, well, let's move beyond the sort of early stages, Agnes. I'd like to show you and everyone this map. It's the Global Health Security Index from October 2019, ranking countries around the world, in part on how they might deal with a COVID-style scenario. The US, Western Europe and Australia are ranked highest, fast forward to today, and Rwanda has seen just 30 COVID deaths per million people compared to nearly 2,000 in the US. So what do you think the other lessons are that can be learned, Agnes, for the rest of the world?
I was again on mute.
Yes.
That's an interesting question, and we know also the answer to that. We know that the projections are not done correctly and that they are not fair. They don't take in account all the contextual factors, and the most important in a pandemic like the one we are in is the trust of the population. And also the political speech and the misinformation at high level that people are not accountable for. So all this put together has made the rich country that was supposed to succeed in preventing the spread of an epidemic or a pandemic fail. They fail because the people didn't trust the scientists. They fail because the leadership have double language and people didn't know what to follow. And they fail because they didn't follow the science. Africa was blessed to have CDC Africa, who called all the ministers of health and told them, this is serious, don't follow what is done in rich country, prepare yourself, etc. So this has helped us to face the first and the second wave. We cross the finger for the third wave because it's different, things are open, and there are variants, and even we didn't have access to vaccine, and countries who have access to vaccine are not necessarily behaving in solidarity for stopping the spread globally. So
All right.
I hope I answer your question.
Yes, you do, Sally, on that. Is it a case of politicians, maybe in the UK, just not listening to the scientists enough?
I think we were all taken aback, and the scientists responded strongly, but did not recognize the need in some ways. And then the politicians had to come to terms with it. But what we also had in Britain was not a resilient population, because our public health in terms of chronic diseases like obesity in particular were not good. We had inequalities. We're a global hub, so people come and go, and a lot of things contributed to the problems of a bad first wave. I think we've improved dramatically since then, and the scientists have been listened to. So it's not a lack of listening to the scientists, but you can look at the different models and predictions, and people come up with different things. And in the end, you have to work with that. Where I feel we were not ill prepared, and I was responsible in my day for a lot of the preparation, was for something that wasn't flu. We had a good plan for flu. We had not prepared for SARS or Ebola. And clearly, we should have done better.
Well, don't forget that in our next session, we'll be hearing from Werner Hoyer, President of the European Investment Bank, and Julia Gillard, former Prime Minister of Australia, now Chair of the Board of Directors of the Global Partnership for Education. We'll also be talking to Anne Ertz, Head of the Novartis Foundation, Angus Deaton, Nobel Laureate in Economics, Carl Manlon, Vice President of Social Impact for CEMIA at Visa, and Nancy Chen, Professor of Managerial Economics and Decision Sciences at Northwestern University's Kellogg School of Management. And a little reminder, of course, you can join the conversation and help spread the word using the hashtag #BackToHealth. Agnes, let's move on to the international response. You did talk a little bit about vaccines. Once a pandemic is announced, your recent work has focused on improving the global delivery of vaccines and making health supply chains fairer. What needs to be radically different by the time the next pandemic hits?
What needs to be different is to have more places where vaccines are produced. And the movement that now seek to have the capacity to manufacture in Africa to be prepared for the next pandemic, because for this one, it's late. It's absolutely crucial. It's not normal that all a continent is waiting for others to be served and be served the last. Also, it's not normal that with the capacity the world has to produce vaccine, people have to die because there is not enough vaccine. So those are the questions we have to solve before the next pandemic and to be ready for the next pandemic.
Tom, I mean, take a look at this chart. For example, if we're talking about funding, looking at the money for the ACT Accelerator, a hugely important effort from the international community to provide vaccines, diagnostic equipment, and other supplies to parts of the world that need it. The budget is $38 billion. Sounds huge, but it's still waiting on roughly half the money it needs. And you compare that to the US's $5 trillion COVID response package. What does it tell you about how seriously rich countries are really taking it? Is vaccine nationalism been too important? And what would the lesson be for next time?
Well, vaccine nationalism is both ethically unacceptable and politically inevitable. And the only way out of it is to expand vaccine production. And we can't simply rely on a few companies to do that. That's not responsible. As big as the financial gap is, for Act A, the bigger gap is that there just isn't enough vaccine. Even if there were plenty of money, there's no vaccine to buy for most countries, and there won't be for far too long. And there is a way out of that. And that's not to fight about intellectual property, I think, but really it's to work collaboratively with government and industry to establish vaccine production hubs with hands-on technology transfer, where you have to respect some intellectual property, you have to provide some royalties, but you have to break the mold of having one or two companies producing the product in 1 or 2 or 5 factories, and instead have hubs that can have resilience, where you have a train-the-trainer approach, where you have the ability to get all of government working together to rapidly ramp up production. We've been calling for this for half a year, and if it had been begun a half a year ago, the production lines would be rolling with hundreds of millions more doses of mRNA vaccines already. This is, I think, the most urgent need right now. mRNA vaccines are our most important insurance strategy against variants, because they are more effective against variants, and against production failures, because it's more predictable to produce. So Europe, with its investment in BioNTech and support for Pfizer, and US with Moderna, should be insisting that these companies not just scale up their own production, but work more broadly to establish vaccine hubs, which will work not just for COVID, but potentially to prevent future pandemics.
Right. Do you agree with that, David? Because you will have heard the arguments rehearsed in the UK that actually it was capitalism, it was the market that were sort of incentivized companies to come up with vaccines. In a recent commentary for Project Syndicate, you called for the creation of a new international financing facility for pandemic preparedness and response. I hope I don't have to remember that. But what would that do? Take us through it.
I hope you do remember it, Joe. It should be tripping off your tongue as a very important reform. Look, I just want to really focus on this point, because Tom and Agnes have made the critical argument about production. There's also the critical need for redistribution of excess vaccines. The world, the International Monetary Fund has said 40% of the world could be vaccinated by the end of the year. But I want to just highlight for you, we don't just need production and redistribution of excess vaccine. We need distribution mechanisms of vaccines in poorer countries of the world, cold chains, taking on misinformation and disinformation, training of community health workers. The places that the International Rescue Committee works, 40 countries torn by war or hosting of refugees, we've got populations beyond the health system, and we've got a massive challenge there for the distribution of vaccines, not just the production of them. Now, in your respect of your point about the financing facility, it's absolutely key that we don't rob Peter to pay Paul, that we don't rob the international funds for universal healthcare in order to pay for pandemic prevention and response. We need a new fund, which is what the panel I was on recommended, that join together pandemic preparedness and pandemic response. It would focus on the global public goods that are distributed at the global level, at the regional level, like the African CDC that Agnes mentioned, and at the local level. It would focus on surveillance, it would focus on genomic sequencing, and it would be ready in the event of a future pandemic for a surge of financing in the first 3 months, because we know there's been inadequate investment in preparedness and too slow funding in response to the pandemic itself.
Sally, you wanted to come in.
Oh, absolutely. But we don't, I agree with David, we don't just need to produce them, we've got to have the logistics to deliver them and make sure we're not wasting them, we're using them effectively. Our Trinity Challenge has got some wonderful data rich using blockchain applications, and we have to bring data science into making sure we use what we've got most effectively.
Right, but Sally, are you worried? You mentioned earlier about other health threats. With all this focus on COVID, of course, understandably and rightly, because we're still in this pandemic, is there a danger in your mind, a real danger, that we miss other health threats?
There is a danger, and if you take antimicrobial resistance and look at the use of antibiotics that drive it, it's been terrifically high during wave 1 right across the world. But the same solutions will be needed for antimicrobial resistance as for this pandemic and the prevention and handling of future pandemics. So again, we need proper surveillance to pick up spillovers from animals into humans, a One Health approach. We need the data about what's going on. We need a re-energized scientific pipeline with better vaccines and new drugs, and that needs different forms of funding. So very similar issues, but focused on the slow pandemic alongside this acute pandemic and the future risks. And I pray
and in terms
that
of,
we'll move forward.
Yeah. I mean, Sally, you also mentioned a bit earlier about the preparedness for flu, that there had been a focus on that because that was what was expected in terms of what was coming down the track. How different does the planning have to be depending on the disease or the pathogen?
Well, you need different approach perhaps to diagnostics. I think I would now argue you'd want to test for flu as well. But previously, the experts felt that we probably didn't need to. So we need to dust those plans off, but we did not have this expectation of an infection that was infective before the patients knew they had it. So actually, what we've got to learn is to be much more flexible as new things hit us so that we respond effectively, whatever it is.
We're going to talk about something just a little different. Agnes, on the screen now, you can see some of the many human behaviours which are thought to make the chance of new diseases entering human circulation more likely, from deforestation to farming methods, intensive farming methods and more. And now I'm going to come to David Miliband in a moment on what richer countries can do. But without support from donors, how will and middle income countries, Agnes, dependent mining and other potentially risky activities, change their behaviours without risking their livelihoods?
Not only that, but everything linked to the change in the life of our planet. I think example have to come from those who have the means, and people who are working to survive day after day and are not so much concerned. Those that are going to do great furniture for the high income countries find the problem where the money comes from. So that's true. We need to change the way we live, but we need to share the capacity to have a decent life across the globe. And also, David, to complement what Sally was saying, we need resilient health systems. Create them now, because the response that we have done successfully is not because we have the money. We have $820 per capita, what is peanuts compared to yours. However, what we did is based on truth and resilient health system. The world have to work on that as well.
I mean, David, how do you do that? How do you change people's behaviour? Why should they change their behaviour in those quite sort of precarious industries and in parts of the world where they don't have much money, unless there is more support from richer countries?
Well, you're right that richer countries and richer people do need to do more. I mean, the truth is we're living on average as if there are 3 planets rather than 1, and rich countries are living as if there were 5 or 7 planets rather than 1. And that is the cost that we're beginning to see in the climate crisis, but also in the resource stress around the world that is a problem in and of itself. but also a stressor that leads towards conflict and other challenges. And so I think that the demand for living within the constraints of the planet is the right guiding light. And in terms of what richer countries can do, surely it fits into two categories. One, they have a responsibility to get their own house in order. And the greatest effort must be made by those countries with the greatest capacity. Secondly, they've also got to be part of global solutions that allow for leapfrogging development by the poorer parts of the world without passing through the stage of high carbon dependence that the rich world has, quote unquote, enjoyed, but which in fact is now paying, the whole world is now paying the price for. And that is a very big long-term challenge. I think that we're seeing the final stages of climate denialism being played out in the United States. But I'm very struck that in China, in India, and in Europe, the debate about the climate crisis and what to do about it has changed fundamentally since I was Environment Secretary 15 years ago. And the best evidence of that is how private money is now flowing into renewable and low carbon solutions rather than carbon dependent solutions. The question is whether or not we can increase the pace. And that's where the responsibility on the rich world in the run up to the global climate conference in November is so grave, because we're not working or moving fast enough to reach peak emissions by 2030. And that's what needs to happen.
Tom, you touched a little earlier about on the issue of the origin of COVID, and recently whether the origin may have been in a lab, or you said it could happen in the future. Do we need new structures in place to address the possibilities of a man-made disease which could even be released deliberately in biological warfare?
Absolutely. And even if we won't be able to completely take that risk off the table, we can make a lot of progress. Right now, there is essentially zero global collaboration, global oversight on work with dangerous pathogens. And I think we can look at the nuclear world, we can look at chemical weapons, and think of a kind of regulatory inspectional scheme that, even if not perfect, can greatly reduce the risks, because we have more and more powerful biological tools that can make dangerous organisms. And whatever happened in Wuhan, we know that in the United Kingdom, smallpox was released, and there was a death as a result. In the SARS outbreak in 2003, 2004, 3 different countries had laboratory releases. Most likely in the late 1970s, the former Soviet Union accidentally released an influenza strain that spread around the world. So laboratory errors occur. Laboratory work is very important, but we have to do much more to make it safer all around the world.
We're going to hear questions from international media in just a moment. Can I get a really, really quick answer from all of you to the question, can we ever be in a position to say there will never be another pandemic? Sally? Oh, Sally, I think you might be on mute. So was that a no?
It was a no.
Right. David? David?
We can't stop outbreaks. We can stop a future pandemic.
Agnes?
I think the world, part of the world will not learn enough to stop the next pandemic, but I wish so.
Yes, I think we all wish that. Tom?
In medicine, we say never, but we can never be so underprepared as we were this time.
All right, let's open up the discussion to questions from journalists from around the world. We're going to start with Catherine Duan, Head of Business Management in China. Catherine, your question to the panel.
Okay, good morning. My name is Catherine. I'm the North American chief at Sina Finance. It's a great honor for me to join the discussion. As a topic discussed today is preventing the next pandemic, my question is, what solutions would be able to prevent the next phase of the pandemic and ensure that the economy can continue to open? Thank you.
David? David, do you want to kick us off?
I think that the question was posing that the economy and health are in tension. But I think what we've learned is that good health policy and good economic policy go together as long as you protect the poorest. And it seems to me that the radical innovation that we've seen in economic policy over the last year and a half around the world is an indicator of the kind of thinking that we need.
Tom?
Well, I think first off, for the current pandemic, We need to ramp up vaccination and double down on the things that work: masking, distancing, ventilation. In terms of future pandemics, really we need to do three things. One, invest in public health systems so that we can achieve the 717 goal. Second, invest in primary healthcare systems so we detect faster, vaccinate better, and have a more resilient population. And third, make sure that we keep doing that year after year and don't have the kind of on again, off again approach to prevention, because that's what will really cost us lives and economic prosperity.
All right, let's take another question from Paul Waldie, Europe correspondent, Globe and Mail in Canada. Paul, your question.
Hi there. Thanks for taking my question. I wanted to go back to this issue that I think Tom raised just briefly, and that is this whole question of intellectual property as a way of increasing vaccine supply. I mean, as I understand it, historically, pharmaceutical companies haven't really invested in vaccine technology because it just hasn't made any money for them. And suddenly COVID's brought all kinds of opportunity for that. But I wonder, this whole issue of waiving patent protection, at least temporarily, certainly President Biden's embraced this and lots of others have, and it's really divided countries. And I know the WTO is taking this up, but I just wonder, is that really a solution? Would that work?
All right, well, let's put that actually, because we heard what Tom had to say on it. Tom, if you don't mind, I'm going to put that to Agnes first of all. Agnes.
I think that for this pandemic, it will not work. It's a little bit late. But the lesson to take out of it is that it should be a early decision when the world faces the same problem. And also, all those big pharma have made their discovery with the money of taxes of their countries. So this intellectual property should be owned by the people, not by them.
Sally?
Well, my understanding this time is that it's too late. The issue is lack of basic products to make the vaccines. And I absolutely think we need to develop a system where we make vaccines faster. The G7 committed to 100 days to produce the first vaccine from the first genome being sequenced. But then I agree with Agnes, we need manufacturing around the world, and we need to have thought through our supply chains. Back to logistics and data again. How do we make sure it all flows effectively? And we're going to have to pay something in insurance for the technology transfer to these new factories, and to make sure that PPE and the basics for vaccines are available when we need it. After all, there was a glass shortage at one point of the special glass. So it's not just the deep science, it's quite, what sound basic but aren't.
Right, I'm going to read the next question on behalf of Ashok Bhattacharya, Managing Editor of Business Standard in India. His question is, we still do not know clearly if the COVID-19 pandemic was caused by a virus leak from a laboratory. Is there a need for a global compact among research organisations on ensuring greater transparency and coordination amongst themselves to prevent such mishaps from occurring? Sally, can I put that back to you?
Yes, I don't mind where COVID came from. The end result is horrible. But I do think, along with Tom, that we need a structure going forward that protects us much better. Smallpox wasn't only acquired in a laboratory in Birmingham in Britain, but also in a laboratory in Russia. So whether it is through a system like the chemical warfare system or what other intergovernmental structure, I don't know. But I'm not sure we can leave it to scientists, and it's generally scientists who run research organizations on their own. I think society needs to be part of that. So I'm going to delegate to the governments.
Right, well, we're going to our final question, which comes from Dr. Olu Kayoda Oyeleya, Consulting Editor from Business AM in Nigeria. Would you like to put your question?
Thank you very much. The question I would like to ask at this point is about Africa and understanding the fact that we have infrastructure constraint, particularly public health infrastructure. I've listened to Agnes made some point, but I want to ask, going forward, since Africa has been very lucky at this point in time not to have had as much of and morbidities as earlier predicted, how can we get Africa prepared to avoid any other pandemic in the future that may play through to the predictions of people who, looking at what our constraints are, thought maybe Africa was going to be seriously devastated, in the future? Should there be any other pandemic of this sort, or probably something that is more virulent than COVID-19? Thank you.
Agnes, I hope you could hear that question, but the key point really was that perhaps Africa had been lucky and that actually the infrastructure constraints are in place. May not be so lucky next time unless those are dealt with in terms of health provision.
So let me remove the word lucky, because the Ministry of Health in Africa have done what it takes and follow science. It's work, not luck. Now, for next time, we need to really create resilient health system, and also to provide Africa with the capacity to manufacture what they need to not die and to survive for the next pandemic. That means from education to infrastructure to a partnership with the big pharma. And I'm so shocked about the intellectual property issue. Coca-Cola is all over the world and everybody pay a tribute to Coca-Cola. And you have Coca-Cola factories in all countries. We can have the same for health.
All right, thank you to all of our questioners there, all the journalists from around the world, and of course to our guests. Thank you to you very much for a fascinating discussion and your predictions to some extent for the future. We're going to be taking a short break before our second and final session of the day, looking at the progress that is and isn't being made towards the goal of achieving universal health coverage by 2030. But before we go to our break, we have a couple of little treats ready. First, here's Seth Berkley, CEO of Gavi, the Vaccine Alliance.
With more than 170 million people infected, 3.7 million deaths, and more than 300,000 new cases each day, this COVID-19 pandemic is far from over. But through vaccination, we can protect people and end the acute phase of the crisis by early next year. Today, more than 2.1 billion doses of COVID-19 have been administered, but most have been used in a small number of high-income countries. Global access is critical to stop the spread of the virus and the emergence of new variants, because no one is safe until everyone is safe in a global pandemic. Even though COVAX has already delivered more than 88 million doses to 131 economies, we need to get there much faster. Currently, more than a third of people in high-income countries have been vaccinated, while in low-income economies, less than 1% of people have received their first jab. Due to generous support, COVAX now has the financing to provide 1.8 billion doses to lower-income countries by the end of the year, beginning of the next. However, there continues to be supply constraints. So as a global community, we need to see vaccines provided now. We're working hard to remedy this inequity now, but next time, and it is evolutionarily certain that there will be a next time, how do we do better? With COVID-19, it took just 327 days to produce a vaccine, the first of 15 now in widespread use. But next time, how do we get there in less than 100 days and ensure that vaccines reach people in all corners of the world rapidly, fairly, and equitably? To do that, a number of pieces have to be in place, but we don't have to reinvent the wheel. Our experience with COVID-19 has shown that much of what we need already exists. We just need to build on it. The first is the ability to rapidly develop and approve safe vaccines that protect against an as yet unknown threat, and do so at breakneck speed. Increased investment in R&D for pandemic vaccines could get us there faster, particularly plug-and-play technologies like mRNA vaccines. These not only make it possible to identify and develop antigens rapidly, but much of the regulatory testing and approval can be done in advance, even before we know what we're up against. We will also need a global distribution network and supply chains to actually get those vaccines out to people quickly. With COVID, we were able to build on the pre-existing strengths of the partners that make up COVAX to ensure that all of the logistics, personnel, monitoring, and data systems were in place, as well as the necessary compensation, liability, and indemnification safety nets to start rolling out vaccines to lower-income countries just 39 days after people in high-income countries got their first jab. But hoarding and export bans of vaccines, as well as the vital components needed to make them, remain major obstacles to supply. For future pandemics, the only watertight solution is to increase global supply and globalize it. With COVID-19, this lack of geographic diversity in manufacturing has been a major choke point. By making investments now to build additional capacity in the global south and further devolve manufacturing away from the global north, we would get the ability to produce the large volumes needed and at speed during a crisis. For decades now, we've had a global network of vaccine manufacturers and suppliers kept busy churning out seasonal flu shots. When a flu pandemic strikes, these facilities can rapidly shift production.
That was Seth Berkley, CEO of Gavi, the Vaccine Alliance. Now, coming up in our second panel today, we'll be hearing from Werner Hoyer, President of the European Investment Bank, former Australian Prime Minister Julia Gillard, who is now chair of the Global Partnership for Education, and Angus Deaton, Nobel Laureate in Economics. We'll be back after just enough time for you to make a quick coffee and check your emails. I'll leave you now with Dr. Gro Harlem Brundtland, former Director General of the World Health Organization, former Prime Minister of Norway, and current member of the Elders. See you in a minute.
Although the COVID-19 pandemic is still very much an active crisis, history has told us it is never too soon to consider what actions we need to take on the lessons we have learned. The recommendations by the Independent Panel on Pandemic Preparedness and Response are a good place to start. In the immediate term, we urgently need to have vaccine equity be the guiding principle underpinning the global recovery, with high-income countries providing both vaccine supplies and finance to lower and middle-income countries. We need a global mechanism to ensure equity in vaccine distribution in preparation for the next pandemic. We must also reform trade and intellectual property rules to allow for greater vaccine manufacture in developing countries, as was previously achieved during the HIV/AIDS crisis. We need an international agreement that incorporates mechanisms for sustainable financing at scale. This logic of solidarity and mutual dependency guides my work as co-chair of the Global Preparedness Monitoring Board and the Elders Support for Universal Health Coverage. In September 2019, the GPMB launched a report that warned world leaders about the likelihood of an imminent pandemic and argued that states should take preparedness much more seriously.
We have therefore made the assessment that COVID-19 can be characterized as a pandemic.
Sadly, too few leaders had paid sufficient attention also to the GPMB's recommendations before the pandemic struck, which has had disastrous consequences.
Brazil tonight is going from bad to much worse.
The U.S. has once again topped its daily coronavirus death toll.
This proves a point that is all too familiar to those of us who trained as medical doctors. Investment in prevention is key. The global experience of COVID-19 has also underscored how crucial it is to have competent, empathetic, and principled leadership that builds trust with its citizens. Across the world, it has often been the poorest and most marginalized in society who have been worst affected in terms of health outcomes and the pandemic's economic and social impact. Leaders should ensure that their recovery plans at a national and international level are aligned with the constitution of the WHO that envisages the highest attainable standard of health as a fundamental right of every human being. In order to realize this vision, fully overcome COVID-19, and ensure that hard-won gains on development and gender equality are not swept away, we need to remodel global public health policy around three key pillars, as the WHO has done. Prepare for future pandemics, support universal health coverage at national and global levels, and promote healthier societies through holistic policies and social development. In these endeavors, leaders and policymakers should be guided by the words of Nelson Mandela. Health cannot be a question of income, it is a fundamental human right. 14 years ago, I had the great honor to be invited by Mandela to become a founding member of the Elders, the group of former global leaders who work together for peace, justice, and human rights. At the launch event in Johannesburg on his birthday in July 2007, he charged us with a mandate to inspire hope where there is despair. Today, we all have responsibility to act in a spirit of hope and determination to ensure just prevention of the next pandemic, leaving a legacy to our children and grandchildren that would make Mandela proud. Thank you so much.
Le confort que nous avons gagné depuis ces quelques années est incroyable. L'espérance de vie de l'humanité était environ 45 ans, il est près de 70 aujourd'hui. La mortalité des enfants a été divisée par 3. On est tous beaucoup plus riches. Avant, il y avait une personne sur 3 qui avait faim, aujourd'hui c'est une personne sur 9. Notre confort de vie a été incroyable. Et à côté de ça, il y a un prix à payer. Tout ça, c'est dû malheureusement aux énergies fossiles, en grande partie. L'homme est en train de complètement consommer la planète. Et je peux vous dire que depuis ces 50 ans de vie, d'intérêt pour la nature, je l'ai vu de mes yeux. Aujourd'hui, quand le WWF nous parle, par exemple, que nous avons perdu 70% du vivant En 40 ans, c'est un chiffre incroyable. Je l'ai répété tellement ça me paraît fort. On a perdu 70% du vivant en 40 ans. C'est incroyable. Il y a environ une dizaine d'années, nous consommions tous les jours 90 millions de barils de pétrole. Aujourd'hui, on en consomme 100 millions de barils. Ce qui veut dire qu'on sait ce qui se passe avec le changement climatique. Nous sommes tous au courant et nous faisons le contraire de ce que nous devrions faire. Tout homme politique a comme mission de rendre heureux ses électeurs. Et de rendre heureux ses électeurs, c'est bien sûr d'avoir la croissance maximum et de préserver le pouvoir d'achat et préserver les emplois. Et ça, c'est complètement en contradiction avec ce qu'on devrait faire aujourd'hui. Il faut qu'on apprenne tous, nous les pays riches, à vivre mieux avec moins. Et tant que la base, tant que les citoyens n'auront pas compris ça, quand on ne sera pas des millions dans la rue à manifester contre le dérèglement climatique, c'est nous qui avons le pouvoir, ce n'est pas les hommes politiques. C'est à nous de changer d'abord et de pousser les hommes politiques qui viendront avec nous. Il faut arrêter de dire que c'est la faute des hommes politiques, que c'est la faute des lobbies, c'est la faute de mon voisin, c'est moi qui est responsable. Qu'est-ce que moi je peux faire? Qu'est-ce que je peux changer? Donc, on a tous très bien compris que décarboniser nos vies, c'est toucher à l'économie. Et aujourd'hui, dans ce moment avec le Covid extrêmement compliqué, je pense que la priorité, c'est préserver les emplois, sauver les emplois, sauver le pouvoir d'achat, c'est la première priorité. Vous savez, il n'y a pas de vaccin contre le dérèglement climatique. Il n'y a pas de vaccin, il n'y a pas un miracle qui va arriver pour tous nous soigner. Le dérèglement climatique est là. Les scientifiques nous parlent aujourd'hui de climat qu'on a eu pendant 20 000 ans. Qu'est-ce qui a changé dans notre monde aujourd'hui? La vraie révolution, c'est pas les avions qui volent dans la rue, c'est pas ce qu'on imaginait à l'an 2000, c'est la communication. Et en même temps, les réseaux sociaux de le monde entier nous montrent quel est le paradis dans lequel nous vivons. Quand vous vivez à Brazzaville, ou vous vivez à Addis Abeba, ou vous vivez au Nigeria, vous avez le paradis sur votre téléphone, vous n'avez qu'une envie, c'est d'y aller. Et quand le changement climatique va en plus vous permettre d'avoir moins à manger, moins de travail, eh bien vous viendrez chez nous. Je pense que la grande crise migratoire n'a pas encore commencé et que le monde va être bousculé d'une façon incroyable dans les 20 ou 30 prochaines années et il faut s'y préparer et on ne s'y prépare pas du tout. On pense que ça n'arrivera pas, mais il n'y a pas d'autre solution que d'accueillir ces gens. Le secrétaire général des Nations Unies a parlé d'une catastrophe imminente. On estime quand même qu'en 2070, si on continue comme ça, près de 3 milliards de gens ne pourront plus dans les endroits où ils vivent aujourd'hui. Et où est-ce qu'ils vont aller ces gens? Ils iront dans les pays riches. Chez nous, là, la solution elle est assez simple. On devrait chaque année consommer 5% en moins d'énergie fossile. Est-ce qu'il est possible de décarboniser nos vies? C'est la chose la plus facile à faire. Et pourtant, ça va toucher notre économie, donc personne n'a envie de le faire. On a chacun une responsabilité. On a tous peur de la mort, on veut tous une meilleure vie pour nos enfants. Voilà, de toute façon, on a tous la mission de continuer d'essayer de changer le monde. Quoi faire d'autre? Être persuadé qu'on peut y arriver. Voilà. Et c'est pas prétentieux de penser que chaque citoyen peut changer le monde. On peut tous, qu'on soit architecte, qu'on soit boulanger, qu'on soit homme politique, qu'on soit chauffeur de taxi, on a le devoir et la mission de changer le monde, j'en suis absolument certain.
Hello again, I'm Jo Coburn and welcome to part 2 of Back to Health, Making Up for Lost Time, brought to you by Project Syndicate. In this session, we'll be drilling down into the promise of universal health coverage for all humanity by 2030, made by the world's leaders as part of the Sustainable Development Goals. That was, of course, a pledge from the pre-COVID era. So, is it still achievable? Was it ever achievable?
A promise by world leaders to everyone and everywhere.
Well, here to answer those questions, I'm delighted to be joined by Angus Deaton, winner of the Nobel Prize in Economics and one of the world's leading experts in development and inequality. Anne Aerts, head of the Novartis Foundation, a leading light in using data and digital technologies to transform healthcare. Carl Mannon is Vice President of Social Impact for Central Europe, the Middle East and Africa at Visa. And Nancy Chen, Professor of Managerial Economics and Decision Sciences at Northwestern University's Kellogg School of Management and Funding Director of its China Lab. Now, don't just leave it to the panel. You can get involved in the conversation too, and please do, using the hashtag #BackToHealth. But before we go any further, to kick things off, here's Werner Hoyer, President of the European Investment Bank.
Ladies and gentlemen, it took a pandemic for universal healthcare to gain center stage in policy discussions about development. Good health allows children to learn and adults to earn. It helps people escape from poverty and provides the basis for long-term economic development. We all have the moral duty to work towards this universal goal, but it also makes clear socio-economic sense. This pandemic has exposed huge global investment shortcomings in the health sector, not exclusively, but most notably in low and middle income countries. This gap can only be closed through large-scale investment in innovative solutions and services, and by global cooperation supporting these. That's why international financial institutions like the European Investment Bank have an important role to play by tackling gaps in healthcare systems. With COVID-19, our support focused on innovative life science companies developing vaccines, tests, or cures for the coronavirus. We also provided early support to COVAX, which provides equitable access to COVID-19 vaccines for people in less developed countries. On top of this, we are extending our direct support to countries across Africa, Asia, and Latin America. Pandemic preparedness and universal health coverage will also require significant efforts from private sector. At the EIB, we have just launched a new initiative with the European Commission, SHIRA, Sustainable Health Industry for Resilience in Africa. SHIRA aims to support private sector projects that increase health manufacturing and supply capacity. We have experienced in our partnership with the Bill and Melinda Gates Foundation that the combination of grants, advisory and loans can unlock private sector investment and generate a significant developmental impact. This is what we need going forward. Innovative financing schemes that shift from a fully donor-based approach. Attracting finance for development impact is important too. The EIB issued its first sustainability awareness bonds dedicated to health last year. This is an instrument that can help bridge the investment gap and crowd in investors while providing transparency and accountability to the market. Basic services, innovation, fair access to supplies, partnerships. Without holistic support for healthcare, the next health crisis will be even more devastating. Some crises are already knocking on our doors. Let's keep the momentum built with the pandemic response for decisive action. And let us face these challenges together as a global community with global responsibilities. Thank you for your attention. I wish you a fruitful discussion. Stay healthy.
Werner Hoyer there, President of the European Investment Bank. Now, don't forget, a little later on, we'll be hearing from Julia Gillard, former Australian Prime Minister and Chair of the Global Partnership for Education. And just one final reminder that if you would like to join the conversation or help share the word today, we'd be delighted. Get involved using the hashtag #BackToHealth. Anne, I'm going to start with you because I'd like to sort of quickly define the terms that are being used so the audience around the world is completely clear, because different terms are used in different countries. So what is universal health coverage and how is it different from universal health care?
Thank you, Joe. Yeah, universal health coverage means that there's everybody in the world has access to the essential health services they need, regardless their income, regardless the place they live, regardless wherever they are. So it doesn't mean free healthcare for all. It means everybody has access to the health services they need without suffering from a financial catastrophe because of the health service costs. So that's what universal health coverage stands for. And we are still a little far from it. To reach the goal by 2030, we will have to rethink really seriously how we are going to achieve it. With the current situations and the current health systems we have that are mainly focusing on care instead of looking at proactive, being predictive and preventive systems that can keep their populations healthy, it's going to take a lot of efforts.
Right. Well, you said it's how you actually achieve it. I mean, UHC will need governments, but also the private sector. But why should corporations, technologists get behind this rather than any of the other sustainable development goals, like tackling climate change, for example?
Well, first and foremost, we heard that health is really the basis of all economic development. But secondly, if we don't start to think about the beautiful opportunity we have of living in this digital era, to make use of this innovative technology to also reimagine our health systems and the way we deliver health and care around the world. It can very well happen a large part outside of the health system. You don't need to build hospitals necessarily if you can handle a lot of the things outside of the brick and mortar of the health system, even in the living room of people. Because if people get more responsibility for engaging in the management of their own health, that has proven to be very successful, for example, but also using data to help the decision makers in the governments on the ground to guide them where the interventions will have the impact on the largest part of their populations. That will be hugely beneficial as well.
Right. I mean, Nancy, how important is universal health coverage in your field of development economics? I mean, is it just one priority amongst many or a goal that should be prioritized over others?
So I think universal health coverage is very important. You know, it's one of, but it's more complicated than just providing healthcare to end users, right? So to get them health coverage, we have to build up the infrastructure within the country and to build up government capacity. And most importantly, to make sure that we have enough healthcare workers to take on these jobs. So it's really a complex bundle of policies that's going to have to be implemented, including capacity building, education, as well as the most direct aspect of health delivery.
But Nancy, do you think it should be prioritized then, taking all that into account over other goals?
So I think it should be prioritized, but not over things like building up education and making sure that governance issues in poor countries are improved, right? I mean, how are we going to improve healthcare coverage and provide aid and assistance to countries that don't have sustainable governance structures within them already?
Okay, well, just bear that in mind, the rest of the panel, because I will come back to that issue. But Angus, I'd like to take you back to 2015, when the United Nations agreed on the Sustainable Development Goals. It was a massive global event, attended by the likes of His Holiness the Pope and capped off with a performance by the pop singer Shakira. Let's just remind ourselves of what she had to say.
We live in a world in which many of those who are born poor will die poor. And it is up to us to be the first society to eradicate poverty and bring justice and equality to the most disenfranchised people on earth. Our children have the right to equal opportunities, to thrive, to be happy and healthy and safe.
Angus, do you disagree with any of that?
Well, I love stirring words. I think they're wonderful. But it's obviously good to alert people to the terrible deprivation that exists in so many parts of the world, and exists in even the richest country in the world. The problems are the problems, I think, that Nancy began to talk about, and I could list a whole lot more, which is not the desirability of doing these things. They're infinitely desirable. The question really is how you bring it about. And actually, you know, saying these terrible things are happening and we ought to focus on them, that's all to the good. But unless we have a path forward, it's not really going to help anyone.
Now, in terms of that, Carl, why should African governments spend their limited resources pursuing universal health coverage rather than perhaps narrower, more concrete policy targets like vaccination drives or providing malaria treatments?
I don't think it's an either or, because you cannot potentially develop countries with corpses. So what is important is to think about development as a continuum. And if I'm in a rural area and I'm focusing on producing agriculture, which is important for the development of a country, of a continent, can I have access to basic health services so that diseases, the group of diseases like neglected tropical diseases, no longer affect me? And I think African government, yes, have limited resources, but they also have the largest and youngest population in the world, which means that the issues of the African continent are actually issues of the world. We can't separate this conversation. And limited resources actually provide also an opportunity. If we think about the assets that government have, the question is for long-term financing of health, can we start to look at those assets as potential collateral to build the capacity that we need in the health system to make sure that we advance development as a whole and not look at health, look at a bit of education and so on and so forth. So I do think that resources are important, but if we manage better what we have a way forward.
Angus, do you agree with that?
Yeah.
Sorry, you're just taking a sip of water.
I would, yes, I think everything's important. I mean, it's very hard to order things and decide what's important, and anything's important above anything else. And, you know, democracy is very important, health is very important, education is extremely important. I would, however, attach some priority to health status, just because if you're not alive, and we're still talking about many, many places where children don't survive the first 5 years of life. If you're not alive, all these other things are not much use to you. So I think health has some claim to be the first thing we should look at. I think it's an incredibly important indicator of how well a society is doing. And I think, you know, one of the most terrible things I've been working on is just the decline in life chances in America, in the richest country in the world, where life expectancy is falling. And, you know, if you lose your life, you can have all the money and education and thing in the world, but it's not much use to you. So I think of health as really being the first among many, while not discounting the other things at all. So we should really focus on everything, but health is, you know, without that, you have nothing else.
Right, but then let's look at some examples, Carl, where people or countries have made great strides towards achieving UHC. If we're taking health here as the example, Costa Rica, Thailand and Rwanda, there aren't that many examples. Why have they succeeded?
If you think about Thailand, there's a strong industrial tissue, which means that you have more people that are employed, that are producing and are helping the economy grow. Therefore, resources to focus on health become possible. If you think of Rwanda, there's a whole plan that focuses on industrialization and development of the country. Health is seen as a leverage to make this happen. It's seen as something outside of a discussion of development. And unfortunately, that's what we see more and more. Yes, COVID-19 has reminded that it is important to focus on health, but we always knew that. Even the discussion around producing vaccine on the continent, we know today that $14 billion is what Africans spend every year to import medicine into on the continent. So we have worked on the industrialization to make sure that we don't spend $14 billion every year to import medicine.
I mean, Nancy, people may be surprised to hear what Angus is saying, that actually even within countries like America and the UK, parts of Europe, that actually health outcomes can be particularly poor for certain parts of the population because of inequality. Does that also need to have a light shone on it?
Yes, I think so. The fact that there are such great disparities in health outcomes within a country is really important for us to address when we're talking about universal healthcare coverage for rich countries and also for poor countries, right? Like people who live in a city in Uganda or Rwanda are going to be really different than people who live in rural areas. For that matter, in China, people in cities have access to middle income country level healthcare, whereas people in rural areas have access to negligible levels of healthcare, comparable to the poorest countries of the world. And this is really important to take into account when we think about how we're going to deliver healthcare to the whole population.
Anne?
Yeah, I cannot agree more with all these points. So you need the visionary leadership, and the success stories you mentioned, Joe, of Costa Rica, Rwanda, and Thailand, it really showed these were countries that primarily invested in primary care, which means that their governments had the visionary leadership to see that it's much better to prevent people to get to the hospital than to wait until they get in the hospital. So if you use the example of high blood pressure, for example, you know that if you treat high blood pressure early enough, you will prevent people from doing a heart attack or a stroke. And that would be much costlier to the health system, if you may, than if you treat them in the primary healthcare. So I think the population health approach is also crucial if you really want to achieve universal health coverage, or you end up with a very specialized type of health services that doesn't cater to the needs of most of the people. And that's why it's so important to have that population lens, that health equity lens. It's so true that even in the US and in European countries, health equity is a spotlight now, on the spotlight now, thanks to COVID, I would say, because it's high time this gets addressed. It's no use that if you live in one zip code, you have a 20% higher risk of a stroke than if you live on the zip code next door. This is really scandalous. It means there's something more than health to health and only health care. And that's the problem of the health equity issue. So it's about the health care. Okay. Yes, it influences health, but very little. Most of the influence comes from the underlying determinants, which is the socioeconomic status or other living conditions for people. And that needs to be addressed at the same time as the healthcare system itself.
So in your mind, Angus, what would it actually take to make UHC a reality?
I actually don't know the answer to that. I mean, I live in America, which spends 20% of its GDP on health, and it's a disaster here. And we don't have universal health coverage in America. And I think we Americans and British people too, who have done better in many ways, but have been disastrous in other ways, really don't have the standing to lecture poor countries on how they should provide health. Maybe they should be lecturing us and telling us how they do that. It certainly requires political commitment. It requires a real belief by ordinary people that community health is really important. I very much agree with these ideas that primary health care, mother and infant provision is absolutely key. And without that, we're really not going to get very far. And we don't do that very well in rich countries.
Right, well, Angus, I'm going to stick with you for just a moment because I'm going to show the other part of the SDG promise on this issue, which is not just to provide coverage, but to make sure that it doesn't put households into too much debt. Now, you can see on this map, it shows where households have to spend more than 10% of their budget on healthcare. You can see the US is level pegging with parts of Africa, Pakistan, and other much poorer countries. I mean, how comparable is the picture in the US to parts of the global south, Angus?
It's actually much worse than that graph looks. I really don't like these graphs at all. I mean, I've just written with Ann Case a book telling us that healthcare spending is impoverishing Americans, is largely responsible for the health inequities that we have. And those numbers, I mean, it does no good at all if the government provides healthcare and takes away from all the other things that people need to survive, which is what's happening through the private sector and through government sector in America. So those maps are terribly, terribly misleading.
Oh, well, I'm sorry we showed it to you, but thank you for putting it into some context in your own words. I mean, Nancy, over the last 40 years, China has lifted more people out of poverty faster than any other example in human history. Healthcare is still not free at the point of use, and the costs are still a burden for many households. Why?
Well, I think the answer is pretty straightforward. Even though Chinese GDP has grown a lot, in per capita terms, it's not that rich of a country. It has an enormous population, and half of that population, which is around 600 million people, that's equivalent the size of the population of all sub-Saharan African countries, have the income that's the same as an average income of sub-Saharan Africa. So, so what China needs to do to provide universal healthcare coverage goes beyond providing it to people who live in cities who are pretty well off today. China needs to provide healthcare coverage to people in rural areas, hundreds and hundreds of millions of them. They're very poor, their local governments are very poor. They're doing better and better year by year, but they're still at a level of a very poor country.
I mean, Carl, do you accept the point that Angus has been making, not so much about the map, but about the levels of spending on health lose their salience and impact if other things aren't there, or they're taken away even by governments in parts of the richer world?
So one of the indicators that we like to push around is saving lives. So if a life is saved by treatment that has been subsidized for, let's say, HIV, TB, or malaria, or any other disease, and I die of COVID, what's the value of investment? And I think the discussion for me has to be around micro, small, and medium enterprises. How do we ensure that the economy is working because people have jobs, and because they have those jobs, they start to think about the future differently. They start to think about their own health, their family, their education, and so on. But if we continue to confine the discussion to how much has been spent for health to resolve that small problem, yet there are other problems, then that investment is not necessarily the best investment. Ultimately, the example about China was about moving people out of poverty because the industrialization process happened. So universal health coverage maybe should be universal business coverage, because with MSMEs that are stronger, you have stronger economies and people actually can make choices as to what kind of help they need. And I agree with Anne, prevention is better than cure.
But Anne, you've written about and talked actually about how digital technologies can help to expand coverage, such as providing medical information and patients having control of their own data, even to remote areas. But I mean, you would accept the vast swathes of the globe where there isn't reliable internet access.
Yeah, exactly. That's a condition that is not fulfilled. Unfortunately, Joe, still half of the world is not connected to internet, and that has to be a call to all governments to make sure that they get their populations covered, connected. I mean, because broadband is an underlying enabler for achieving all of the sustainable development goals, not only the health goal. And I think it's crucial that that has to be looked at as well, because we've seen, it's true what you say about China, and I agree, China still has a lot to do, but if we look at how China is using digital and AI solutions in its health system, There's for example, one thing that struck me is Ping An Good Doctor in China. It's one company that wants to deliver every household in China with access to a doctor, to a health record, and to a health management plan. And they deliver everything on internet. So through their internet hospitals, internet health centers, and internet pharmacies, even 24/7 services, home delivery of your goods and medicines you would need. They do 1 billion consultations a day. So it shows you that you don't need to have specialists in all rural areas. You can centralize expertise if you use digital technology. And if you use AI on top of that, you can really create these insights that will help the decision makers allocate their scarce resources to those interventions and public health interventions that will have the greatest impact on their populations. And that is really an enabler we shouldn't forget, because this is what COVID brought us. COVID catapulted us all in the digital era, even got the most skeptical ones amongst us medical professionals over the line of using virtual care because it has so many more benefits than risks. So that is really crucial, I feel.
Nancy, you've been nodding away. Just before I get you to respond, I just want to remind everyone watching that still to come, we'll be hearing from Julia Gillard, former Australian Prime Minister and chair of the Global Partnership for Education. You agreed, did you, Nancy, pretty well with what Anne was saying, particularly with the example of China?
Yes, so I agree. So thanks for bringing this up, Anne. So for the last 3 or 4 years, I've been talking to companies in China that have been trying to introduce internet medicine. And, you can imagine how difficult it is to introduce medicine over the internet to reach rural populations who may or may not have access to high-speed internet. And one of the really exciting things and promising developments during COVID was the vast rollout of internet medicine a year ago, encouraged by the Chinese government and in collaboration with, huge companies in China like Alibaba. And I think at the beginning of last year, the statistics I saw that 42% of physical hospitals nationwide established internet medicine. And this can reach rural households. It's obviously they give contactless delivery. They're able to provide real-time care. Patients only need to go to clinics if they need to see experts or to get additional diagnostic help from, x-rays and machines like that. So I think this is really exciting, and if China can roll this out, then I think other countries can benefit from its experience and also roll out similar services to help those rural populations that we were talking about, especially during a contagious pandemic.
Carl, do you agree with that?
The challenge that we have is electricity. For internet to function, you need electricity. And if a majority of the population still doesn't have access to electricity, AI and all these interesting technology may not work. And I think when we think about technology, it has to solve it has to be for a purpose and solve a real situation. So yes, it's important, and I don't disagree. Majority of Africans still don't have access to electricity. And how do we solve this? We have to find a solution to make sure that we improve that. Solar technology will help. And once we have access to electricity, maybe the first thing is not AI. The first thing could probably be better access to water, access to education using digital platforms, and so on and so forth. So I do think that we have to look at what technology can do and not only focus on urban realities. The majority of the African population is still rural, and we'll probably get to a 50-50 in a couple of years. So the majority for me remains the important part in this discussion.
Angus, there's no doubt that the pandemic has reduced GDP dramatically. It's sucked up so much government spending and aid. Do you agree that the bill for UHC will actually probably have to be picked up by rich countries?
No, I don't. I think that's a terrible idea. I think several of the documents emphasize the importance of community involvement, of community healthcare. That's something that countries have to want for themselves. They have to be prepared to organize it. And the track record throughout the world of which countries try to provide primary healthcare systems for poor countries is little short of catastrophic. We have a really huge opportunity right now, which is to make sure we get the vaccines out there. And that's something that I think we can do. I think we ought to do it. I think it's possible to do it. And I think it probably will be done more rapidly than many people fear it is. And so that, I think, is something that we really should push for. We should really focus on right now. Now, primary health care systems can really help that. But several countries have done very good vaccination, very successful vaccination drives, including the US, without using its healthcare system at all. Most of those vaccines in the US were delivered not through the healthcare system, but through local authorities, through the army, and so on. In Britain, it's the opposite case, where they had very successful vaccines that were provided through their primary healthcare system, which is very effective at doing that. But the idea that somehow we can double down by using our money in rich countries to support healthcare systems that local countries are not fully behind is just dead wrong.
Carl?
I think we are entering probably the most complex phase of a pandemic, and thinking about UHC, because science has delivered a ray of light, and unfortunately that light is not shining on every country or every population of the world at the same level. And that demonstrates a particular issue, the fact that because we did not think about the technology that is required to protect our own population in time, we are at the mercy of certain choices that today we are facing. Thinking about another entity solving your health problem is a challenge, because ultimately it is the ability of a country to make sure that all the workforce has the required capabilities to transform that society, which is critical. So I do think that, yes, the resources are limited, but what we have should be helping us to think through primary healthcare, solving some of these basic issues for us to move forward.
Nancy, what do you think about that idea that Angus says is dreadful, not a good idea, to get the richer countries to pick up the bill for UHC?
So I agree with the point that you can't really force people to take on a service or assistance if they don't really want it themselves. That said, for the countries that want it and that want to implement it, I think rich countries can assist. I mean, we're already assisting, right? Rich countries, because COVID is different from diseases like Ebola, it's contagious and it affects rich countries. Rich countries have developed the vaccines. This is a big deal. So the vaccines are already there. The money for developing them, figuring out how to produce them and distribute them and implement them have already been figured out by rich countries. And I think this is something that poor countries can leverage, the poor countries that want to leverage it when they want to roll them out. And the same principle applies for all aspects of health services.
Okay, I'm going to show everyone these diagrams, Carl, from the WHO's 2021 World Health Statistics. It shows the number of people per physician in different parts of the world, with just one doctor for every 3,600 people in Africa. And here's the picture for nurses and midwives. Given the time it takes to train medical professionals, and we have just 9 years left to hit those SDGs, it doesn't seem massively realistic.
It doesn't it doesn't. But we have to remember that in 2014, 2016, when we had the Ebola outbreak in West Africa, the African Union financed, with a private sector support, health workers that went to help to end Ebola in West Africa. We have health workers that today are helping the continent to stay healthier with the COVID-19. So when we think, it's true that the numbers are very dismal. But the reality is that with what we have and the health workers that we have, they're doing an extraordinary job at keeping us healthy, many of us, and moving forward. So the community health workers conversation is an important one. But I remember asking the question, what is the pathway for a community health worker? You cannot be a community health worker for the rest of your life. Therefore, how do we help communities to think about prevention and being able not to get to the point where it is so bad that they need extra care or very sophisticated care? Yes, we don't have all the resources, but what we have should help us to build stronger system for the development of a continent.
And do you agree with that?
Absolutely, yeah, and that's even a better example of how UHC is ultimately, it's a choice of the leadership in a country if you want to deliver universal health coverage or not, and that choice has to be made by every country itself. And I cannot agree more with Carl that health workers currently and before as well were already delivering an extraordinary job. But let's not forget indeed that we have a shortage of about 16 million skilled health professionals in the world. How on earth are we going to train them rapidly enough with this rapidly aging population, the rapidly urbanizing population, and all these challenges we already have, like the emerging new diseases, or the dual burden of diseases, or the rising tide of chronic diseases, even in low and middle income settings. So there's a real need to reimagine our health systems. And that's why I am so passionate about the use of data, digital, AI-driven solutions. Understanding we need electricity everywhere, but I am also in favor of those people who call broadband connection as important as electricity as water and should be in every home, in every household around the world. If we don't want to have anyone behind and really have universal health coverage, we are not going to do that without having digital connection and digital access to health. In fact, there's a discussion going on of making digital determinants of health another social determinant that is at least as important as the socioeconomic determinants of health. So definitely a believer, we need to accelerate connection in the world and the people's skills to be able to be savvy enough, digitally savvy enough, and having the data skills, the data science skills to use it to build these insights that policymakers and decision makers need.
Angus, are you optimistic that the digital determinant that Anne and Carl have been talking about is achievable in the near term? That connecting perhaps some of those communities, those poorer communities in countries like America, that's going to be the big solution?
I don't think anything's the big solution, but I do think that the digitization can certainly help. I think it's really a bad idea to jump on particular solutions and say this is what's going to solve it, because you just play into all sorts of bad things, which I won't talk about. But I do think that one of the, as has already been said by Nancy and others, the COVID pandemic has taught us that a lot of medicine can be done usefully remotely and can be done usefully digitally in both rich countries and poor countries. Of course, there's restrictions because of electricity and all the rest of it, and those things have to be done together. But yes, there's great promise there, and this can make the relatively few doctors that there are in some places spread their usefulness much more widely than has been the present right now. We don't get it too done gung-ho about technology and digitization, for instance, and there's one of the things I worry about a lot is tech firms like Apple who are putting health devices on people's arms, which it's true will warn some people that they're sick before they know it, but it'll create hundreds and thousands or millions of healthy people who will think that they're sick and put further pressure on the healthcare system. That's a really good example of where prevention is actually much worse than. So we don't want to jump onto simple one-side solutions, and we give enormous power to digital providers if we go with a single solution. They can be useful, but they're only a part of whatever the solution might be.
Right, Anne, I want you to comment on this graph, which we're going to show people. It's how external aid for health has risen this century, but at the same time, government spending on health in lower income countries has decreased as a share of total expenditure. Why?
Why? I think there's definitely in the play that the health needs in countries that were originally donor countries have been increasing a lot with the aging population may play a role, the politics may play a role, definitely. But also, I believe that if we look at the needs in the world, health spending from donor or overseas aid, let me say it like that, has always classically been focusing on mother and child health issues, infectious diseases, and never on the chronic diseases. You know that chronic diseases like cardiovascular disease, cancers, respiratory disease, diabetes, they receive 2% of the overseas development aid across all these years. And they are responsible for the majority of the deaths over the world. Cardiovascular disease is the world's leading cause of death. High blood pressure alone causes 10 million deaths a year. That's more than all infectious diseases combined. So no one was really paying attention to that, as there's no health security engaged, if you want, for chronic diseases. And that has been the most flagrant gap, I believe, in the overseas development aid currently and previously. So that is something we should all look at in a perspective, where did the money go to?
Okay, well, what do you think, Angus? Because you've long been critical of foreign aid and Western interventions in developing countries in general. What do you think?
I'm not a fan of the non-communicable disease agenda. I think it would be better if the share of non-communicable disease deaths were even larger than it is. And that's because people who die of non-communicable diseases, by and large, die in old age. And I think our priority is something we know how to do, which is to save the children first. And, you know, there's a lot of doom and gloom about this, but one of the things we should focus on is the enormous amount of success over the last half century. At least before COVID came along, we don't really have good data for COVID yet. There's no country in the world where infant mortality now is higher than it was in 50 years ago. And that's an amazing achievement. It's not an achievement of us. I mean, it's not an achievement of aid agencies, it's not an achievement of the rich world. It's an achievement of the countries themselves using technology and ideas and vaccines, many of which were developed in the first world, but not universally so. And that's an enormous achievement, and we need more, not less of it.
All right. Well, listen, thank you very much for the discussion so far. It's time to open it up to questions from journalists around the world. We're going to start again with Catherine Duan in China. Catherine, your question to the panel.
Okay. Thank you. Given the fact that the Federal Reserve has printed billion notes and the inflation rate has reached 5%, my question is, what do you think that the inflation rate will go by the end of next year? Will the stock market and the dollar continue to inflate? Under the current situation, what would you advise people to protect their wealth?
It wasn't very clear, the line. I don't know if the panel could hear. I might have to get you to repeat it. But Nancy, if you could hear it, can you take no? Catherine, I'm afraid none of us could quite hear the question. The line is not great. Can you just try again?
Okay. Given the fact that Federal Reserve has printed billions notes and the inflation rate has reached 5% right now, my question is, what do you think that the inflation rate will go by the end of next year? Will the stock market and the dollar continue to inflate? Under the current situation, what would you advise the people to protect their wealth?
Right. It is, I think, about protecting wealth. There was so much in there of the stock market. Nancy, I think this is a result of the pandemic. I'm sorry that the line is not. How can countries protect their wealth going forward when they're going to have to spend so much in COVID recovery?
Okay, so I think I heard most of the question. And first of all, I'm going to say I'm not the right type of economist to answer that question. That said, my understanding of why the stock market is doing so well right now, based on my reading of the news and what macroeconomists say, is that it's really a lot of it is about the very aggressive stimulus spending by the current US government. So, and this seems like it's continue at least in, for the foreseeable future.
Angus?
I think the stock market, it's interesting, the stock market in America has gone through the roof. The stock market in Britain has not, for example. And some of it's attributable to government spending and some of it's attributable to low interest rates. And that's true in all countries, though, so that can't explain the American difference. The big run up in America is because of the incredible success of the big tech companies during the pandemic. And that's created a lot of wealth, not just for the billionaires. And by some accounts, Bezos's wealth has doubled, which is already more or less the richest man in the world. But also many ordinary people in America have had huge gains through their retirement portfolios. I think it would be incredibly desirable if we could find some way of taxing that wealth that's a result of the pandemic in the rich countries and using it to finance some of the damage that the pandemic has caused. I'm really worried that in many of the rich countries in the world we'll go back to some sort of austerity so that the people who suffered most during the pandemic would have to pay for repairing it, and that I think would be an outrage.
Carl?
I think all has been said. I don't have anything to add to that.
Anne, what about you? Do you agree with what Angus has said, though, that you could tax that wealth and it could go towards paying and funding the recovery?
Well, I'm not an economist at all, but I would agree that it can help in the recovery. But I think there's many other things that have to be solved as well before only thinking about the funding.
All right, we're going to move on. Thank you for your question, Catherine. Let's go to Paul Waldy, Europe correspondent, Globe and Mail in Canada. Your question.
Thanks very much. I just wonder, in a similar vein, you know, all of this money that is being pumped into the economy, particularly in the US, but also, you know, lots of other Western countries in particular, is that going to make a difference, both in terms of maybe closing some of these economic gaps that we've seen grow over the last few years? Is it going to make any difference in the healthcare outcomes? I just wonder what impact all of that money, government money into the economy, is going to have.
Angus?
Yeah, I mean, I think we don't know is the answer. Many of us are very hopeful. The labor market is really doing relatively well for less skilled people in the US, who've had a very, very rough time, not just pre-pandemic, but for the last 50 years. And if that's the case, and if we can make life better for less educated people in America, the fact that their lives have been getting shorter, that people without a BA in the US have seen life expectancy falling for a decade, which is just an outrage. And maybe COVID will help turn that around if this is done sensibly, but there's lots of forces pushing in the opposite direction. And I worry about that.
Carl, are you optimistic about that?
About the African continent, at the moment, we don't have the same size of a stimulus. We can't afford the same size of a stimulus. And I think what this demonstrates again is that we have to make sure that we build these economies to be more industrialized, to build these economies to improve micro, small, and medium enterprises, because those are the ones that create wealth. And without the wealth creation, so changing the end of poverty narrative to wealth creation, we can sort of ensure that we aspire to have resources to fund the next recovery if we are faced with a similar challenge in the future.
Right, but Anne and Nancy, I mean, people will watch countries where there has been huge amounts of stimulus going in, huge amounts of government intervention, and will perhaps get used to that and think this is what we can stick with going forward. We haven't gone bankrupt, so let's keep going. Nancy?
Yeah, so I wanted to actually add on to something that Carl and Angus said. So I think, you know, in terms of all this spending on in COVID, and all the money that's being pumped into the economy, some of it seem, great in that, we're developing vaccines that's going to help everyone in rich countries and poor countries. But a lot of it is to remedy the increased inequality that COVID caused, right? Like if you look at the US, we see unemployment rates hitting women, hitting minorities, hitting poor households much harder than the wealthier parts of society. So a lot of the money that's being pumped in is just to remedy that, to take us back to before COVID. I don't see signs that we're going to be better than the pre-COVID era.
Anne?
Well, I think it's really time to also look at the fact that we are even facing a syndemic, in fact, where COVID coincides with existing epidemics like cardiovascular disease that were insufficiently addressed across the globe. And that convergence with social and economic underlying factors that make people who are living under low income have a higher risk for the complications of both of these problems, COVID and cardiovascular disease, plus the risk of the infection made that most people with chronic diseases or conditions have postponed their healthcare seeking behavior and are now being diagnosed with late stage cancer or with acute events that could have been prevented if they would have sought healthcare earlier. So this created, in fact, in low and middle income settings where we are working in several countries currently, but we see that it created much more poverty than there was before. So that will have to be addressed with some kind of economic support, because this poverty is going to have long-lasting effects together with this endemic of existing problems and the higher burden of COVID on the lowest income communities or the most unequal areas of the world.
Thank you for your question, Paul. We're going to take a final question from Dr. Oluyokayode Oyeleye, who is the consulting editor at Business AM in Nigeria. Your question.
Thank you. My question is about the healthcare services in Africa, which obviously is very much affected by the state of our economies, and manpower and facilities are very much deficient in terms of availability, and there's also a problem of affordability of healthcare services, to many Africans. Given the low percentage of budget devoted to healthcare services in Africa, for instance, like Sub-Saharan Africa has about 5.08% as part of their budget, for healthcare services. My question has to do with this. How can we really get the authorities in various countries of Africa to actually take more of the revenues and plug into a higher budgetary allocation for healthcare services, so that more people will be able to access healthcare services in Africa? Because presently now a lot more of our budget is devoted to debt servicing, debt repayment, than we actually devote to healthcare services. So, I'm talking about prioritization now.
Right, Carl, what's your reaction?
I think there are two parts. The first part, if you have a minister of finance or planning of a country, and you have scarce resources, and you have this windfall that is coming from development assistance for health, your priority towards that may not necessarily be the focus because you have so many other issues. The second part is that we continue to produce raw materials and export raw materials. Therefore, we are stuck with the cyclical prices of commodities. And if we look at the price of oil, it has really plummeted over the years, which means that most countries' budget had to shrink. So the question is always, how do we create more value so that the resources that we have on the continent increase and we can certainly allocate more resources to health? If we just speak about health without thinking about how do we transform these economies, then we have a problem, because the revenue is not going to change if we continue to export raw materials.
Anne?
I think it's to increase health budgets in Africa is absolutely a key for the achievement of universal health coverage. That's clear, and it requires again this visionary leadership that makes the choice to invest in the health sector. But it also requires intersectoral collaboration. For example, of ministers of finance talking to ministers of health is quite rare. So we've seen that in many countries, there's a very little conversation between the departments, and the Minister of Health is often not so well foreseen with budget as many other sectors. And that is absolutely key, that it becomes much more an intersectoral collaboration in the government to understand that health is the driver of all the other sectors if that is not addressed. But I cannot agree more also that we need to create more value, because it's not only about health systems and increasing the capacities of health systems, it's about increasing the quality of care. We know that in the world there's many more people who are dying of low quality of care than of lack of access to care. And that is really a crucial element. If we talk about UHC, we have to talk about access to quality care and not just access to care, because people are financing and getting into poverty because of financing their health services that are of too low quality with very low outcomes. So that is a key question also for many governments around the world, not only in Africa, definitely globally.
All right, that is all we've got time for. But can I say a big thank you both to the journalists for asking the questions, but particularly to our wonderful panel and guests. And thank you for being so adaptable to all the questions that were thrown at you. Thank you for that discussion this afternoon. Now, what better way to wrap things up for today than with Julia Gillard, former Prime Minister of Australia and chair of the Global Partnership for Education. Here she is.
Hello everyone, and thanks to Project Syndicate for inviting me to participate in this important discussion about how to bring our communities, countries, and indeed the entire world back to health. As the chair of the board of the Global Partnership for Education, I am acutely aware of the abundant evidence that better education is pivotal to better health outcomes. A child whose mother can read is 50% more likely to live past the age of 5. Educated mothers are also more likely to vaccinate their children. So key to solving the health challenge is getting all children, especially girls, in every part of the world into school and learning. At the Global Partnership for Education, for 2 decades, we have been driven by this goal. We have seen steady progress in the many countries where GPE works, but even before the pandemic struck worldwide, about 250 million children were not in school. Unsurprisingly, the pandemic dramatically intensified that already long-simmering global education crisis. At the peak of the pandemic, more than 1.6 billion children were unable to go to school. When children miss precious days in the classroom, there's an obvious risk that many of them will fall behind. Some will recover lost ground, but others will struggle to make up for that learning gap for the rest of their lives. For children in lower income countries, where there were few any resources to provide distance learning during the pandemic lockdowns, the risk is even more acute. There continues to be deep concern that these disruptions could become permanent for the most at-risk children, particularly girls. An estimated 20 million girls may never set foot in a classroom again because they have been sent to work to help provide for their families as a result of the pandemic. As many as 13 million could be forced into early marriage, putting an abrupt end to their education. For millions of others, school closures have increased their risk of teenage pregnancy or of becoming victims of domestic violence. In our view, at GPE, the reopening of schools should be accompanied by efforts to transform education systems entirely, rather than simply returning to a status quo of unequal opportunities and poor learning outcomes. Already, pre-pandemic, over half of all 10-year-olds in lower income countries lacked basic reading skills. In addition, governments must shock-proof their education systems for the future. That means not only developing and integrating distance learning options, but also ensuring that schools have proper sanitary facilities and are teaching basic hygiene. Teachers need training in new methods, and we need to ensure that children who rely on their school for at least one meal a day don't go hungry during a crisis. At the end of July, the UK and Kenyan governments will co-host the Global Education Summit, aiming to raise at least US $5 billion to support the Global Partnership for Education's work to transform education for children in 90 countries and territories where schools are not only essential for learning, but also critical to children's welfare and security. Investing in safe, inclusive and quality education should be at the centre of pandemic recovery efforts and will provide a buffer against the next crisis. Without a solid foundation of schooling and learning, we will never achieve the goal of giving everyone around the world the opportunity for good health. Together we can, and indeed we must, do more.
That was Julia Gillard, and this has been Back to Health, Making Up for Lost Time, brought to you by Project Syndicate. Thanks once again to all our contributors, everyone working behind the scenes, and most importantly of all, to you, the audience, for watching. See you next time.